A very good evening, everybody. On behalf of AOGD Multidisciplinary Committee, I welcome you all for a complete academic extravaganza this evening with the webinar on everything about Rh-negative pregnancy, a multidisciplinary approach. Rh-negative pregnancy is such an important and pertinent topic. It has to be followed not only in the index pregnancy, but also has implications on future pregnancy. So let's learn everything about Rh-negative pregnancy, from the recent advances in early genetic diagnosis to management of iso-immunized baby, to a detailed explanation and discussion of the management of Rh-negative pregnancy from the stalwarts themselves. To start the academic sessions, I welcome Dr. Shashilata Kabra, our chairperson of the Multidisciplinary Committee, to please introduce our chief guest and guest of honor today. Welcome.
Welcome all. Thank you, Ankita. Please, Shivam, please display.
Shivam, please display ma'am's slide.
First of all, I welcome Dr. Achala Batra, ma'am. Ma'am has joined and we are very pleased, ma'am, that relieve it, Ankita. It's okay.
Shivam, please
yes.
display the next slide.
Just wait. First, I welcome Dr. Achala, ma'am, our president of AOGD. And we are very thankful to ma'am that ma'am has taken out her valuable time and has joined in spite of her very busy schedule. Achala, ma'am. Can you hear me? Hello.
Call Joshna because my network in this village is very poor.
Okay, so, ma'am. Okay.
You may
okay.
Call Joshna.
Yeah. So, Shivam, please display Dr. Joshna Suri's slide. So, on behalf of the Multidisciplinary Committee of AOGD, I welcome our chief guest, Dr. Joshna Suri, who is the Vice President of the Association of the Obstetricians and Gynecologists of Delhi, the largest OBG society in India. She is relentlessly working hard to achieve safe motherhood in India, and ma'am doesn't require an introduction as she is well-recognized figure in our OBG society. She is well known for her contribution towards the care and management of critically ill obstetric patients, and she is a passionate teacher too. We are grateful to ma'am for accepting our invitation and becoming the chief guest of today's event. And thank you so much, dear ma'am, for the love and affection you shower on us. Ma'am is, beside the vice president, ma'am is also the national corresponding editor of Jogi 2021-23, chairperson of Safe Motherhood Committee in 2019 and 21, chairperson Multidisciplinary Committee of AOGD 2016 and 18. Ma'am is the former editor of Association of Obstetricians and Gynecologists of Delhi Bulletin and in charge of critical care obstetrics of Safdarjung Hospital since its inception in 2016. And ma'am, please
go with the program now.
Ma'am, please speak a few words of wisdom for us.
Yeah, so I would really like to congratulate Dr. Shashi for organizing this program, which is truly, I think, fitting, the criteria for a multidisciplinary webinar. Actually, with, the different professionals required to manage such a case, who is a Rh iso-immunized case. It is not just a obstetrician or a fetal medicine specialist. We need a geneticist, we need a neonatologist, we need the blood bank physicians. So it is it requires the multidisciplinary coordination of so many professionals. So I think it is a very, very relevant topic which you have chosen, Shashi, and I'm sure, as always, your webinars, you put your heart and soul in organizing it and making it a grand success. And the, audience who is there logged in are going to have a real scientific treat with such dignitaries and people who are, such authorities on this subject. So all of them have come today evening and spared their valuable time. So on behalf of AOGD, I welcome you all and really thank you for being there with all of us. And we will be, anyway, this meeting is recorded. So even those who are busy and cannot join in right now in the live program can get the benefit of this from the website, AOGD website. So Shashi, thank you once again for inviting me, and I think we can go ahead now.
Thank you so much, dear ma'am. And thank you so much for enlightening us and for such kind words. Now I welcome our chief guest, Dr. Sheila Mane, ma'am. So taking out this evening further, on behalf of everyone present here, I heartily welcome the guest of honor today, who is none other than our most respected Dr. Sheila Mane, ma'am. Ma'am is currently the DNP faculty at KCG Hospital, Bangalore. Is a acting member of ICOG Governing Council, President ISOPAP Society, Bangalore, President Bangalore Menopause Society. Ma'am has experience of more than 2 decades working in FOXI. Ma'am was the Vice President of FOXI in 2014, and truly ma'am is called the PPH Lady of whole India and served as teacher for more than 30 years in various medical colleges. Ma'am is the recipient of Best Teacher Award for BR Medical College and received the Best Society Mehru Dara and Hansotia Award for Safe Motherhood Committee, and ma'am has served as National Facilitator for Adolescent Health and received MS Signature Award for phenomenal leadership in providing high quality of emergency obstetric services. And ma'am has immense contribution in the prevention and management of postpartum hemorrhage, and which has saved lives of many women in India. And ma'am is going to contest for the post of ICOG Vice President 2022. We convey our best wishes to ma'am and request you to enlighten with your words of wisdom, dear ma'am.
Thank you. Thank you, Dr. Shashi. Thank you for the invitation, for giving me this opportunity. I would like to thank Dr. Achla Batra and Dr. Joshna, as well as Dr. Ankita also, for giving me this opportunity. It's a proud moment for me for being a guest of honor for AOGD program. And I like the title, that is the multidisciplinary theme. Okay, excellent, Shashi. That multidisciplinary theme is really a very good title. And I know that today you have stalwarts and Rh negative pregnancy is so important, where I think the fetal medicine specialists play a very big role, because we really depend on them. And today's webinar, I'm sure, highly will enlighten a general OB/GYN that what they have to do, when they have to do, and when they have to refer the patient for all these special investigations and ultrasound and to fetal medicine specialist. And the another important thing is involving neonatologists, because it is a teamwork. And unless and until we are working together, before even if we take out the baby, we have to talk to neonatologist. So it is very important. And I see that there are Meenakshi Pradhan is there, who is our national, I think at FOXI, she is the chairperson of the Fetal Medicine Committee. So, and Dr. Vatsala, who is going to conduct the panel. Dr. Archana Aparna is also participating in that, and many known faces in Delhi. And thank you very much for inviting me once again. I think all are academicians today. Okay. And ICOG really look forward to that. So with God's wish, if I become ICOG Vice Chair, I know that we will have to take academics to greater heights. Thank you. And I wish all the best and good luck for today's webinar. Thank you, Shah.
Thank you so much, ma'am, for such enlightening words and our best wishes for your candidature. So over to you, Ankita. Ankita, you are there?
Yes, ma'am.
Okay.
Thank you so much, ma'am. As we begin the first session, I now introduce the chairpersons. Dr. Mandakini Pradhan, ma'am is chairperson in Genetics and Fetal Medicine, Committee FOXI, professor and head SGPGIMS Lucknow, and her aim is to establish maternal and fetal medicine in India. Welcome, ma'am. Our next chairperson is Dr. Seema Thakur. Ma'am is senior consultant, genetic and fetal diagnosis, Fortis Hospital, Rainbow Children Hospital, and the Genetic Clinic. She is recipient of title of Professor by Apollo Hospital Education and Research Foundation and a Distinguished Medical Luminary Award, as well as Women's Doctors Association, Delhi. Welcome, ma'am. I request the chairpersons to kindly introduce the speakers for today.
we would require CV. Ankita, we would require CV. So, the first speaker is Dr. Veronica Roda, who is currently associated with the Department of Medical Genetics and Genomics, the prestigious institute at Sir Gangaram Hospital. She has done MS Ops Gynae and DNB in Ops and Gynae, and then super specialty degree in medical genetics, MNA MS. And she is an executive member, Delhi Society of Fetal Medicine. She is a DNB gold medalist with more than 50 papers in peer-reviewed journals of publication and several awards. Her areas of interest include fetal malformations, autism, skeletal dysplasia, genetic metabolic disorders. So I welcome Dr. Veronica. Now you can present your talk today. So,
thank you so much, ma'am, for the kind introduction. So it is really an honor for me today to be present among such stalwarts of obstetrics, gynecology, and fetal medicine. All of you have been the people that we've been reading and always discussing about. So I would like to take this opportunity to discuss a small part of genetics, that is the presence of Rh genotyping, which we are now able to do on the maternal blood and the utility of the same. So I would just share my slides. Are my slides visible?
Yeah.
Okay, great. Thank you. So I'd be just introducing the topic of Rh immunization, the burden, the need of this type of genetic testing in pregnancy, the technology by which we are doing this now, the utility of this, and I'll be talking about the management in brief because that the panel would be discussing later. So the history records how the question by the general physician and a very famous lepidologist who was a butterfly collector. He really helped to make a connection between genetics and Rh genotyping. Prior to 1970s, the hemolytic disease of the fetus in newborn was a significant cause of an infant mortality rate. The incidence of Rh isoimmunization or Rh alloimmunization is different in different countries. In Asia, it's actually, luckily for us, quite less, but because the population is itself so big, the burden is very high for our country also. The HDFN, the hemolytic disease of the fetus in newborn, arises when the maternal anti-D IgG antibody crosses the placenta into the fetal circulation, leading to immune-mediated fetal anemia. The disease can affect all subsequent pregnancy where there is a maternal-fetal group incompatibility. There has been lots of research on the same, and today I am going to discuss some of that. So Rh genotyping was a subject that integrated obstetrics into genetics. So if we look at the structure of the Rh gene, we understand that the Rhd antigen is the most important blood group antigen. And that is because it has the highest antigenicity or the highest antigenicity potential. It is determined by a protein anti-D, which remains the leading cause of hemolytic disease of the newborn. The antigen of the Rh blood group is carried by proteins which are coded by two genes, Rhd and Rhce. So there are two genes which are both located on the chromosome 1, and by 1p36 we mean the different parts of the chromosomes. So both these genes encompass 10 exons and their structure are highly similar to each other. So the Rhd gene is flanked by two homologous DNA segments of 9,000 base pair in length. And this presence of this DNA is what we can go and catch in the maternal cells and get to know the genotype of the baby. The detection of this hybrid rhesus box has been applied to demonstrate the presence of RHD detection. So if there is a deletion of the RHD and the fetus would be Rh negative, then we can detect if the baby has Rh positive or an Rh negative blood group, thereby defining the management options. Hence, it became feasible to distinguish an RHD homozygous from an RHD heterozygous fetus. Such discrimination is of a clinical interest because all children of RHD homozygous father will be RHD positive and at risk of hemolytic disease of the newborn. But only 50% children of an RHD heterozygous father will be positive and would require surveillance, monitoring, and further management in that pregnancy. So what is the burden? Why are we so worried about this? Is it really a genetic sort of a disorder which is very rare? The answer is no. The prevalence of hemolytic disease of the fetus in newborn is about 1 in 20,000 live birth. Incidence of overall maternal alloimmunization is 1 in 300. So when we say that the incidence of alloimmunization is 1 in 300, but the disease is 1 in 21,000, is this gap that we are trying to fulfill by the different management options. But as always, because the cure is always difficult than prevention, my aim today is to get that prevention aspects in place and to prevent how we can prevent this really from happening. So it affects approximately 4,000 fetuses worldwide, of which 15% die before birth. So there is a heterogeneous phenotype. Severe fetal anemia occurs in 10% of at-risk fetuses, is confirmed by invasive prenatal testing, and requirement of blood transfusion is present. About 90% of fetuses in RHD alloimmunized pregnancy have mild anemia or are unaffected also. So it's very interesting to know that we can predict that the fetus is going to have a severe anemia phenotype or a mild anemia phenotype by really looking at the genotype of the fetus. If the fetus is a homozygous for the RHD and the mother is negative, the fetus is likely to have a much more severe anemia and may result in high drops as well. But if the fetus is heterozygous, the fetus will be likely to be having a milder degree of anemia, and maybe the monitoring options can vary as well. Neonatal care of HFDN will be discussed by Dr. Manoj later. So the heterogeneous nature of the HDFN is associated with maternal alloimmunization against paternally inherited fetal RBCs. Exposure to incompatible RBCs also can occur during organ transplantations, during blood transfusions, or spontaneous feto-maternal circulation mixing. And this can trigger maternal alloimmunization as well. It is to be noted that the test I am speaking about, the genotyping, can be done in any of these cases. It can be done in cases of organ transplantation. It can be done in case of other spontaneous feto-maternal circulation mixing as well. So RHD is correlated with highest HDFN related risk. However, of course, we know there are KEL, Duffy, and other ABO incompatibilities which exist as well. So there is a paper by Dr. Mandakini Pradhan ma'am, which says that there is a 26% chance of women whose husband are Rh positive by cytology and heterozygous for Rh deletion by molecular methods. Hence, knowing the Rh diversity of the husband is very important. So when do we really test? So when we take the blood of the father and we see that the father is positive, that the father is homozygous, we know that the baby will always be Rh positive. The baby can be heterozygous or maybe homozygous as well, depending on the mother's status. So in this case, we know that the baby will always be heterozygous, and in that case, we can even predict the severity of anemia in the baby. But we will not do genotyping by the NIPS method because it is not indicated. We already know that the baby will the pregnancy will need monitoring. But when the father is heterozygous, this is the case when we will do the test and see if there is a 50% chance that the baby is positive or negative. So there was a big revolution in the NIPS technology, the non-invasive prenatal screening. Dennis Lowe, he said that we had wasted 8 years of our life by looking at the wrong part of the blood. We were always looking at the RBCs, and we were putting down plasma, which really had what we needed, the cell-free fetal DNA, and that's what we needed to look for. So the plasma is the part of the blood where we have the cell-free fetal DNA, and it is on that cell-free fetal DNA where we perform this Rh genotyping. So he said that I look at myself doing science and I'm almost like a tourist, going places I've never been before and that I might be the first to see. So it was very exciting for him indeed to understand that the plasma was the one we needed for Rh genotyping. So he is the one we really owe all the non-invasive prenatal screening technologies to, including our aneuploidy screening as well. So if we look at a glance at the history of the ILO immunization, we see that this began actually much earlier than we could think of. It began in 1994. So the fetal blood genotyping was introduced. At that time, it was done by simpler techniques like RFS.
Shivam?
Is NIPA. How this has been a game changer in the field of the obstetrics. We all are familiar with the NIPS for the aneuploidies. So the NIPS for aneuploidy is quantitative, where we check the the amount of the DNA and the amount of the cells present. And the NIPS for RH is the qualitative checking. So it is the presence or absence of the RH positive type. Similarly, NIPS for the gender determination for sex-linked conditions, where in other countries where it is visible. So these were earlier introduced. Unfortunately, these are not freely available in our country. So these are the standard of care in many of the Western countries. Like they are for all RH positive, RH negative women. They are ordering this test in the first trimester itself to determine that whether she is carrying a RH negative and RH negative fetus or RH positive, and sensitivity is as high as 99%. The same which we know for the the cell-free fetal DNA for the aneuploidy. And why this all is important? This all is important because and also the resources. We are doing the ultrasound for MCA Doppler for everyone, without knowing whether she is carrying RH negative or RH positive. And also the entity, which is not in too much surplus to provide, all the RH negative women, those who need it. So to, judiciously using all the resources, we need all these advances to, to adapt into our practice. I think the introduction of the RH cell-free fetal DNA and the RH genotyping. And these tests are not very expensive. Again, not like 10,000 or 20,000 like NIPT for Down syndrome. These are 5,000, 6,000, and I think currently Gangaram is doing it, and they've been doing since quite long. I think as long as 10 years, I remember they are doing it. So that is the only place where we can get RH typing. The test is very, very sensitive. To the tune of 19. So we have to be still very vigilant. The lady who has decided to be the RH negative by the cell-free fetal DNA, and still followed cautiously, because there are very rare chances of being false negative. And we have seen once also that we had this, and where we said that this is RH which came from and she went back there. Later on we realized, okay, that this was a RH positive, so this was a case of false negative. So when you are back.
Hi, ma'am. Sorry, I got disconnected.
Okay.
Shall I continue, ma'am?
From the slide where you left?
Yes, ma'am. Yes, ma'am. So we had discussed about the history of cell-free fetal DNA, and so just in brief about what this cell-free fetal DNA really is. So these are fragmented DNA which are shedded from the cytoplasm of the placenta when the placental microparticles are shed. They are approximately 200 base pair in length, and they start shedding at around 5 weeks of pregnancy, and 11 to 13% of the cell-free fetal cell-free DNA in the maternal blood is fetal, and this increases with gestation. And the good thing about this is that it has no memory, that is, it will fall rapidly after delivery, and we will have a new set of cell-free fetal DNA for our next pregnancy. So analysis of cell-free fetal DNA in maternal plasma in what is known as the non-invasive prenatal screening. It is routinely performed for our aneuploidies, that is the 13, 18, 21 and X and Y. But we can also do this now for our genotyping in the RH pregnancies. So actually, initially, we started off by doing the RH genotyping by this method. So as I said, it is cleared from the maternal blood within hours after childbirth. So we can use it in each pregnancy separately. So the technique that we follow here in the hospital is a real-time PCR. We do follow the genotyping by this method. It is quite sensitive, but of course there are false positives as well as false negatives. The sensitivity at best we can say is around 96%, and the false positive rates around 3%, and the false negative rates of around 5%. So we still have to be careful in these circumstances, but a lot of studies are now saying that we are getting there to so as to increase the efficacy, that is the sensitivity and the specificity of these tests. So the protocol that we generally follow here are that we do an initial testing of the antibody screen. If the mother is Rh positive, of course, then no chance of risk of alloimmunization regardless of the typing of the fetus. But if the mother is Rh negative, we do the antibody, and if the antibody is negative, a paternal Rh testing should be done. When the father is Rh negative, again, that scenario is excluded. When the father is Rh positive, there is a 50% risk of having an Rh positive erythrocyte in fetus and higher risk of complications. So that's when the Rh genotyping of the fetus is carried out, and the Rh genotyping of the father can be done by RFLP and PCR to see if the father is plus or plus minus. If the father is plus, like in this scenario, then again the fetus would be 100% Rh positive. We do not know if the fetus would be plus or plus minus, but if the father is RHD plus, that's when we proceed for the same, and this can guide us in many ways. So there are so right now we only talk about RHD, but there are different pathways for immune-mediated red cell anemia. Immune-mediated anemia arises from different pathways exemplified by the differences between anti-K and anti-D as well. For the anti-K, the pathophysiology for antibody-mediated fetal red cell destruction involves destruction of erythroid progenitor cells and onset of fetal anemia. This contrasts a little with anti-D, where antibody-mediated anemia arises from binding to Rh positive fetal erythrocytes. KEL blood group's antigen presents early in development, and through undefined mechanism, the maternal anti-KEL antibodies suppress the erythropoiesis process. So basically, to stay, it is just not D. When we have a recurrent isoimmunization, even after we are giving anti-D, this anti-KEL antibodies should also, the minor blood group incompatibilities should also be kept in mind. So the clinical management to prevent alloimmunization includes management strategies in transfusion are designed to prevent alloimmunization in women with childbearing age or treated appropriately when it has occurred. So for women within childbearing age requiring a transfusion, the primary category is red cell transfusion with antigen matched or antigen negative red cell products. For Rh negative women that have given birth to Rh positive infant, the second category is postnatal RHD immunoglobulin immunoglobulin prophylaxis as well as antenatal prophylaxis to prevent isoimmunization in pregnancy. So in our categories where there not has been alloimmunization, NIPT for fetal RHD genotyping has a role in the latter two categories. That's what I was getting at. So there has been 2 decades of experience about NIPS in RHD, and now this technology is quite in place, and it is recommended that all pregnant women have a blood group and antibody screening that is performed in every pregnancy, and from that on we can go and do the testing, because now the testing itself, the RH genotyping itself, is not very expensive and affordable to a large proportion of people. So there are certain challenges for NIPS fetal RHD genotyping. The first challenge, of course, is that it is not picking up your minor blood groups. And the second challenge is the lack of sensitivity that still exists. And the RHD gene is highly polymorphic with over 410 variants associated with the Rh negative, a weak or a partial RHD antigen positive phenotypes as well. So it is not easy to detect these single nucleotide variations. There can be small insertions or deletions which might not be picked up on the real-time PCR also. And we have to do more sensitive techniques like a digital PCR in some cases. So fetal genotyping by NIPT potentially has an advantage over phenotyping by cord serology, because cord serology may not detect the paternally inherited variants associated with weak D phenotypes, which we can also pick up on the fetal genotyping. So this is one advantage really of invasive of the non-invasive method, except that it is non-invasive in itself. So we can do it. The sensitivity is quite good between 12 to 24 weeks, but for the best sensitivity, we prefer to do it from 12 to 14 weeks. So what are the advantages? One of the interesting advantages are that we do not talk of many times are the false negative blood group in serology. So sometimes a woman's blood group would come as a negative in serology, and when the genotyping is done, we find that there has been some error in the serological methods, and there has been a false negative in the groups in serology, and the mother is actually an Rh positive person. So we do not need the extensive battery of tests. So such genotyping helps to recategorize the status of the mother as well. So across a lot of studies, there has been a 25 to 39% rate that has shown that there has been avoidance of unnecessary Rh immunization that has been given by knowing that the fetus is actually Rh negative. In non-alloimmunized pregnancy, if we do an Rh genotyping, we can avoid unnecessary Rh immunization, and the risk of alloimmunization is of course prevented. There is prevention of a lot of maternal anxiety, and because we are giving all these Rh immunization products, there are theoretical risks of infection, and all this can be prevented by doing the Rh test. And not to mention that the government and the hospitals are saving costs, and a Canadian study said that it has been estimated that $1 million could be saved every year if these tests are performed in time in pregnancies, and we are not giving unnecessary anti-D in pregnancy. And as I mentioned, it saves inadvertent use of blood products and the theoretical risks of infections which exist in them. So finally, NIPT can also be done and is now being developed for catching the atypical red cells antigen, and QFPCR was being used, but now slowly for the atypical antigens like KEL, RHC and RHE as well, we are developing the real-time PCR technology. And as we would be discussing the management in the panel, so I would just be skipping that and coming to the main practical points about RHD genotyping. So we do it in cases where we are suspecting that the pregnancy is Rh negative, and the baby's blood group is to be determined so as to monitor and provide surveillance in pregnancy. The best time to do it is between 12 to 16 weeks, and we would require blood samples of the father, the mother. And initially we do a paternal genotyping by PCR and RFLP method. And only if the father is plus minus, that is a heterozygote, we proceed for the genotyping, thus saving a lot of anxiety, the giving of Rh anti-D, and finally giving that family good hope that their pregnancy would proceed normally. Thank you so much for the patient listening.
So thank you, Veronica, for such an excellent lecture. It was really very, very informative. And I hope this will, improve the standards of care, because this Rh genotyping of father and the NIPS for Rh typing is, standard of care in many Western countries. So maybe more than 10 years. So I think this is the time we start doing, because this will give us a, this will help us in managing the women in a very better way. So due to the paucity of time, we will not be able to do much discussions. Now I invite Dr. Manoj for our next session. So Veronica, you can, we have discussion. So Shivam, I need the slides for Dr. Manoj. So Dr. Manoj is working at Sir Gangaram Hospital in the Department of Neonatology. So he has done his MBBS, MD and DNB in neonatology. And he is currently senior consultant and professor at Sir Gangaram Hospital. And he has a number of publications in Index Journal. And other professional membership is National Neonatology Forum India, Delhi Medical Council India, and he is a reviewer for the Index Journal like Indian Pediatrics, Indian Journal of Pediatrics, Journal of Clinical and Diagnostic Research, Current Medicine and Research and Practice, British Medical Journal. So welcome, Dr. Manoj. Now you can begin your talk.
Thank you, Dr. Seema, for the kind introduction. I think I'm not able to share my screen.
Sir, now you can just try again.
Okay. Is my screen visible?
Yes, sir, visible. Please put it on slideshow, sir.
Yeah.
Yeah.
Yeah, perfect.
Yeah. First of all, I thank the organizing team for inviting me for to address postnatal management of Rh sensitized fetus. Well, postnatal management would depend on assessing baby before, like assessing the scenario even before the delivery of baby, then scenario at delivery room. Then it will incorporate subsequent management while baby is being cared in NICU. So what all we anticipate, the fetus might be minimally affected, where fetus has mild anemia, or fetus might be severely compromised. He might be having severe anemia with features of hydrops, where fetus might be having pleural effusion, pericardial effusion, massive ascites, and the fetus might be hypoxic, acidotic, and this fetus might require extensive resuscitation at birth. So if we are anticipating such kind of scenario where we are going to deal a severely affected fetus, we shall have few provisions already made even before baby is born, where what all those would be, like an O negative blood, which is cross-matched against maternal sera. And then if mother has received, like if fetus has received intrauterine transfusion, then we need to keep this irradiated, gamma irradiated, so that we do not allow GVHD to happen. Then we shall have provisions for emergency drainage of effusion, ascites, and all those kind of situations. And of course, a team which is capable in resuscitating this kind of compromised baby with all kind of IV invasive lines and resuscitation gadget shall be available. And it goes without saying, such kind of babies shall be preferably delivered in a tertiary care center. So in delivery area, we evaluate baby's respiratory status, baby's cardiovascular status, severity of anemia, And if fetus is hypoxic, baby need to be intubated and ventilated as per standard guidelines. And if we are unable to resuscitate the baby, we shall be anticipating pleural effusion, pericardial effusion, and we need to tap that out there only. We cannot expect baby to be shifted in NICU and laser drainage of these kind of fluids over hours. This has to be done over minutes. And if we feel baby is severely anemic and not looking good as far as baby's perfusion is concerned, we place baby like in the aerial warmer in the delivery area itself. We put an umbilical venous line, which is a very simple and easy procedure. And baby might require saline or red cell transfusion right at delivery room area. Okay. And once that all has been done, initial stabilization has been done, baby has been ventilated, we have established baby's homeostasis, baby's perfusion, baby's heart rate, all those things. Then if there is an opportunity, we collect sample and have a quick processing for baby's hemoglobin, for baby's retic count, serum bilirubin, because those are critical samples and there would be few decisions which would rest on value of those measurements. And if the opportunity was missing for a cross matching, then we can have baby's sample and then that cell can be arranged cross matched against baby's own serum. And once baby reaches NICU, again, ongoing evaluation and management of cardiorespiratory status continues. This baby might be born with immature lung, they might be having HMD. So we need to support baby on those lines as well. We need to assess severity of anemia and we need to support baby's hemoglobin status. We need to take care of hyperbilirubinemia, which might rise very rapidly. And then other supportive care like nutrition and rest of the cares. So if we look at management of anemia, how do we go about? There are two kinds of approaches available. One is top-up transfusion, where simply we transfuse red blood cell based on baby's hemoglobin value. If baby has anemia, we transfuse babies around 15 ml per kg, and we may go up to 25 ml per kg depending on severity of anemia. And another type of modality is exchange transfusion, where what do we do? Rather than giving top-up transfusion to the baby, because these babies are already in state of hypervolemia, they are having hyperdynamic circulation, they might not tolerate top-up transfusion. So in such baby, we do exchange transfusion where we take out part of baby's blood, we replace it with fresh blood, and we keep doing this in small cycles. And the idea is to replace double the baby's blood volume, that is around 160-180 ml per kg, is replaced over a period of an hour or so, which will rapidly correct anemia with reduced bilirubin load and will also reduce sensitized RBCs. Then how do we make a decision whether we need to go for a top-up transfusion or we need to go for an exchange transfusion? That depends on severity of anemia and on baby's condition. If anemia is very severe, that means hemoglobin is less than 8 or hematocrit less than 25, and this baby is compromised, baby is already hydropic or baby is having hyperdynamic circulation, then of course exchange transfusion is the only viable option. If anemia is moderate, that is between 8 and 11, we might simply go for a top-up transfusion, where we just give 10 to 15 ml per kg of blood transfusion, which has been arranged and cross-matched against baby sample. And in case of mild anemia, most of the time no transfusion is required. This baby need to be monitored for hyperbilirubinemia, and most of the time these babies are simply managed on phototherapy. And another issue which comes with RS sensitized baby is late anemia. Many times these baby might skip a transfusion early in their neonatal period, but because of ongoing hemolysis of sensitized RBC, by end of 2-3 weeks, these baby might again land up in clinic or in NICU with severe anemia per se, not with jaundice. So we need to anticipate this entity, and we need to, like if baby already has developed severe anemia qualifying for transfusion, we need to transfuse baby at that point of time. Otherwise, if anemia is not very severe, but it is ongoing and it is evolving, then we need to just provide the substrate in form of iron and other nutritional parameters. Erythropoietin is erythropoietin has been there for last 3-4 decades, and it is evolving idea. There was a period in early 90s where erythropoietin was being used left, right, and center. Then there were like concerns with use of erythropoietin. Again, now in recent decade, again there are sentiments for giving erythropoietin, but it's like variable practice. Different centers have different practice of using erythropoietin in patients with anemia and during early infancy or early neonatal period. It has its own plus and minus. So apart from anemia, next biggest issue which is really dreaded because of toxicity to brain is jaundice. These babies with severe hemolysis might be producing like very heavy load of bilirubin, which might not be handled by liver enzymes, and this baby might develop very high jaundice in very quick time, and ultimately they might land up in bilirubin encephalopathy, earlier which we used to call as bind. These days we use term bilirubin encephalopathy. We hardly use term carnivorous or bind kind of thing. And what are the options as far as management of jaundice is concerned? We have phototherapy, we do exchange transfusion, as I discussed earlier, and third modality is intravenous immunoglobulins. So I'll be just quickly touching each of these one by one. Well, if we look at phototherapy, like what phototherapy does, phototherapy transforms the bilirubin into some other kind of molecule which are either less toxic or they are more polar, and which can be readily excreted without involvement of liver enzymes. So that makes bilirubin, that makes brain less susceptible to bilirubin toxicity. When I remember my days of MD training in like 2000s, we used to have very elementary kind of white tube light. I think most of my senior colleagues in the panel in this group might be knowing that earlier we used to have plain white CFL lights, which we use as tube light. But over the period, for therapies evolved, because those lights had very like less wattage as far as efficacy is concerned. Then came era of CFL, that was like special blue compact fluorescent lens lights, which were little better than those earlier primitive white lights. And during last couple of decades, we have LED lights, which are way better as far as efficacy is concerned, as far as luminance is concerned. So if we look at conventional light, that emits intensity in terms of 3 to 6 microwatt per centimeter square per nanometer. If we look at CFL, they have capacity of something 18 to 20 microwatts per centimeter square. And if you look at LED, they might have an intensity up to 50 to 60, even up to 70, 80 microwatt per centimeter square. So LED lights are like way better than CFL, and of late in most of sophisticated units, LED lights have replaced compact fluorescent lens. Then we have other kind of equipment which we call as Billy blanket. So this is the one kind of blanket where baby can be placed over it, and there are other kind of blanket also which can be wrapped around baby, so that baby is receiving phototherapy from all the surfaces. Otherwise, what most of unit would be doing, either they might be having two phototherapy, one from underneath, one from over the top, or more comfortable idea would be making baby lie on a Billy blanket, and then we have on the top kind of phototherapy devices like this. And this is how we, like, these are the charts which are given by American Academy of Pediatrics, which have been there for last 18-20 years without much change. So these are like our specific cutoffs for use of phototherapy in neonates. And we have 3 lines. One is the bottom line is the high risk neonates which are born preterm. Middle line is either babies are born preterm or they are high risk, and top line is babies who are born beyond 80 weeks and don't have a risk factor like RH or any other condition. So we need to choose a line which baby fits in, and then we need to plot the baby's serum value on our specific chart, and we need to make a decision whether baby is a candidate for therapy or not. Another modality which is very effective and very important in neonate with severe kind of jaundice in RS disease is exchange transfusion. In exchange transfusion, what do? We take an aliquot of baby's blood out and we replace it with a fresh blood which has been screened for absence of any unusual antibodies, which has been cross-matched against either maternal sera or against baby's sera. So suppose mother is Rh negative and baby is Rh positive, we are going to have Rh negative blood, Rh negative red cells suspended in AB plasma. And we regulate hematocrit of donor unit also. We try to keep hematocrits between 60 and 70. And then we most convenient is putting a catheter, a small catheter in baby's umbilical vein. Then a small aliquot is given, like we have a rule, like in per kg we take 5 ml. So a 1 kg baby, each aliquot would be 5 ml, and in 3 kg baby it would be somewhere 15-20 ml. So that aliquot goes in, then aliquot, like baby's aliquot is taken out, and we replace around 160 ml per kg of blood over an hour period time, and then we repeat the values, and most of the time the values would go down to 30-40% of baseline, and this would eliminate up to 90-95% of sensitized RBCs. Right? And this would also clear bilirubin rapidly, and this would correct anemia as well. As I discussed, regarding guideline for therapy, similarly, there are specific guidelines for making decision for exchange transfusion. Similarly, we have 3 set of lines. We need to plot baby's value on those lines, and if baby's value is below above the thresholds, we need to go ahead for an exchange transfusion. And even baby's values are low, but still baby is showing signs of bilirubin encephalopathy, we might need to contemplate an emergency exchange transfusion, even if the values are below the thresholds. Well, there are several concerns regarding exchange transfusion. This is an invasive procedure, and as we are taking an aliquot out, or we are introducing an aliquot in quick time, there might be hemodynamic alterations, which baby might at times not tolerate, particularly baby who has been hypoxic, who has been hydropic. And of course, there are metabolic abnormalities in terms of hypocalcemia, hyperkalemia. So we need to be careful of all those possibilities. And blood is a live product. We need to be careful about infections. Then there are a whole lot of immunological reactions possible with use of blood products, like graft versus host reaction, transfusion-associated NAC, transfusion-associated acute lung injury, and there are so many complications which are theoretically possible while we are doing an exchange transfusion. So we need to be watchful of that. And theoretically, there is at 0.5% to 1% mortality risk as well. And this would, of course, need a lot of monitoring and expertise, and is preferably done in tertiary care centers. And third and last gadget, which we practically have in our armamentarium, is intravenous immunoglobulin. How does IVIG work in RS disease? Well, the baby is having RS red cells which have been sensitized by antibodies. So there are antibody sensitized red cells in baby circulation, which are amenable to Fc receptors of RE cells. What IVIG does, IVIG compete with those Fc receptors. So IVIG would occupy those binding sites. So these sensitized RBC would then escape destroying in RE cell. So it would reduce the magnitude of hemolysis. So hemolysis would slow down, so would be bilirubin load. So over the period, ultimately these RBC has to be taken up by RE cells, but rather than being taken up in a couple of days time, this would be taken up in a month or so. So there would be no acute load of bilirubin, and the load which is produced over the period would be very well handled by liver enzyme, which would conjugate such kind of load, and there would be no unconjugated or no severe unconjugated hyperbilirubinemia. Well, we were using IVIG routinely in babies who had Coombs positive hemolytic disease, where bilirubin levels were close to exchange range. But of late, there has been concerns regarding use of IVIG, and during last 5-7 years or during last decade, sentiments for use of IVIG is low. theoretical concerns are again like a blood. This is a biological product. There are like reports of anaphylaxis, thromboembolic event. We have seen a case of IVIG-induced NEC, and there are reports in literature of transfusion-related acute lung injury, of MI, of shock, of ARF, and all kind of complications. They have been reported in literature, and in this list, we have also observed a couple of severe complications. So we cannot take IVIG treatment lightly. And when we look at the evidence, as I mentioned you earlier, this was found to be effective if we look at all the studies available in the literature so far. But of late, there has been reanalysis of same data. And if we take out studies with low quality, then we are left with only 2 studies where either the outcomes or the assessments were blinded. And if we look at those studies with high quality, the benefits are not much. So in lieu of these findings, we have little low sentiments for use of IVIG in RS-sensitive pregnancy with severe hyperbilirubinemia. But if we look at practice worldwide, there is variation in practice. There are a few centers which are still using IVIG routinely. If bilirubin is at the level of exchange transfusion, and it's positive scenario, but few units, including that of ours, we are not using IVIG routinely as of now. Thank you.
Thank you so much, sir. I respect the chairpersons to please give the concluding remarks to sir's talk.
It was a brilliant and mesmerizing presentation, Dr. Manoj.
Thank you, Dr. Shashi.
And we gynecologists, at least we got the opportunity to hear you, because we always miss the pediatric and neonatology part. So that's a great contribution to this multidisciplinary committee.
Thank you, my pleasure.
Chairperson, would you like to give some concluding remarks? Dr. Mandakini, Dr. Seema. So we can move to our next session, Dr. Ankita then.
Yes, thank you, Dr. Manoj. It was really good.
Dr. Seema, Dr. Seema, please.
Yeah, I could join it. So thank you, Dr. Manoj, for updating us for the postnatal management of the RHI isoimmunization. It was really very clear. So we all have been benefited by this. So thanks once again. Now I think we can move on to the next session, Dr. Shashi.
Yeah. Dr. Ankita.
Thank you, ma'am. Thank you for a complete academic feat. All our delegates truly benefited from the vast knowledge and a multidisciplinary approach shared by our dignitaries. As we move on to the next session of a brainstorming panel moderated by none other than our expert, Dr. Vatsala Dadwal. Can we have ma'am CD, please? Dr. Vatsala Dadwal, ma'am is Professor, Division of Maternal Fetal Medicine Division at AIMS, and she is Executive Committee Member, Society of Fetal Medicine, as well as Chairperson, AOGD Fetal Medicine Subcommittee. Welcome, ma'am. I request ma'am to kindly introduce the panelists.
Welcome, Dr. Vatsala.
Ma'am, you're muted.
So we have a galaxy of experts for the panel discussion, and it's my pleasure to introduce them. So Dr. Sashilata Kabra Maheshwari, ma'am is MBE faculty, and she is also an active member as far as academics is concerned. She's also the current chairperson of the multidisciplinary committee of AOGD, and she is also a member of other many committees of FOXI. And welcome, ma'am.
Thank you. Thank you for moderating this panel also in multidisciplinary committee.
Thank you, ma'am. And next I welcome Dr. Rima Bhatt, and she's currently working as Senior Fetal Medicine Consultant at Cloudline Hospital. And she is one of our experts, and she would be deliberating the discussion with us. She's also Executive Committee member of Society of Fetal Medicine. Next, please. And Dr. Nandita Dimbri, she is also a maternal fetal medicine expert, and she's chairperson Department of Fetal Medicine at Sir Gangaram Hospital. Next, please. Welcome, Dr. Nandita. Dr. Parna Sharma, she's additional professor in the Department of Obs and Gynae. She's also maternal fetal medicine expert, and also is recipient of many awards and a very active member of various academic committees and societies. Next, please. And Dr. Manisha Kumar, professor, director professor, Lady Hardinge Medical College, and she's also maternal fetal medicine specialist and also genetic. She's also trained in genetics. Welcome, Dr. Manisha. So we will move ahead. First of all, I'd like to thank the organizers and the chairperson of multidisciplinary committee, Dr. Sashilata Kabra, for giving us this opportunity to talk on a topic which, although may be not of that much interest to many countries in the world, but we still are deluged with patients coming with RH isoimmunized pregnancy who've had very losses. To start with, I think we should try to be on the right side by preventing the problem using anti-D, or if this should be less, that the woman comes with fetal anemia or at high risk of anemia. So we would be monitoring and treating them. Of course, we don't want to be on the wrong side in delivering these kind of babies. So we have a very expert panel to tell us about the management of RH negative pregnancy. So I'll just start. So we already introduced the panelists. So the first question I'll ask Dr. Kabra. So this is a common clinical scenarios that we have in the OPD. So that's how we are going to discuss the cases with more stress on the preventive aspect. So a newlywed couple comes to your clinic. She's 8 weeks pregnant, and we find that her blood group is A negative. What would be the next step? What investigation would you like to do specific to this condition?
Thank you, Dr. Vatsala. So this lady is 8 weeks pregnant and her blood group is A negative. So as a general obstetrician, I would first like to know the blood group of the partner, husband, whether he is RH negative or RH positive. Though there is importance of heterozygous and homozygous, as it is said that with the heterozygous chances of having RH positive fetus is 50% and with homozygous 100%. But usually in practice, we just need a blood group of the husband. And if the husband comes RH positive, then we treat as a case of RH negative pregnancy.
So
and
if the husband is negative, would you like to go ahead and do further testing? Like
no, we will not like to. If husband is RH negative, we will not do any further testing.
So I mean, sometimes we are not aware of the patient's previous history. She may not have.
Yeah, I have to take her history. If she is RH negative and husband is RH positive, then we have to take history of any previous event of sensitization or any previous history of blood transfusion.
So
that is very important.
Husband is negative.
Well, that may lead to sensitization. If husband is positive, not negative.
No, but suppose husband is also negative, but sometimes she may not give you a previous history of pregnancy, like she may have had an MTP, maybe it's a different partner, or
that case it is very important.
So there is no harm in doing. If you have the facility, cost effectiveness, you can do an indirect Scones test. So moving forward to the next scenario. So this is a primary gravida at 10 weeks. Her blood group is A negative, husband's blood group is O positive. So we went ahead and did the indirect Scones test, which came as negative. So Dr. Nandita, I would like to ask, what is indirect Scones test? And how will you follow this patient?
Do I have the liberty to change the management? In this era, when we have been discussing so much about RH genotyping, Dr. Vatsala, would you like to take it as a primary investigation? It's not costing much. RH zygosity, not genotyping. I'll explain what indirect Coombs test is. It is, we are taking the sera and the RH sensitized cells, what you have already given us here, is it's an agglutination reaction where anti-human globulin is being used. So depending upon the load of antibodies, it agglutinates to the RBCs and give us a reciprocal of that in dilution. That is indirect Coombs test.
So yes, you can go
No,
ahead.
but I would be very, at this panel, can we have a consensus? Like, is it so difficult? Like in a primary, if we are going on investigating, we are talking about cost effectiveness. As Dr. Seema said, and as Veronica said, is it too difficult to bring it into practice? RH zygosity.
So it also depends on the availability, affordability, and other issues. Definitely it is available,
Because,
it can be done. It's not a...
Anti-D itself is costing 3,000 rupees, and we can avoid an anti-D in these cases.
Yeah,
If
so
the,
I think
if
I think depending on the setup you're working in, even like for our patients, they may get anti-D free of cost, or the monitoring is done free of cost. So for them, the kind of patients we get in the government referral hospitals may be different. But definitely, if the technology is available, it should be offered to women. I mean, I think
because
other
we could
panelists
avoid,
want to give their point of view depending on their practice.
Right. And if in such cases, if her ICT is negative at 28 weeks, she becomes a candidate, because we feel that transplacental hemorrhage increases in the third trimester. So she becomes a routine candidate to receive antenatal RH prophylaxis at 28 weeks if her ICT is negative. And then within 72 hours after delivery, when you ask me the management, what we are following.
Yeah, that is absolutely correct. And as far as doing the fetal RH status, or the husband that is homozygous, heterozygous, I think maybe in future it will become more of a routine thing. But as of now, it may not be available to everyone. But yes, it's good to be aware about it. So this patient wants to know if a baby is at risk in this present pregnancy. Dr. Manisha, how would you counsel this woman?
Yeah, so thank you for having me. Thank you, Dr. Sashi and Dr. Vatsala. So basically, we have to tell this patient that in this pregnancy, there's no obvious danger, but she has to come, at 7th month, 28 weeks to get the testing done. So that testing is very important. She has to be delivered at a place where, all precautions are taken while delivering her, and anti-D is given after delivery also. So she cannot deliver at home and all. So she is a high risk pregnancy, and she needs to be monitored from 7th month onwards. So that was the one. And we would also like to tell her that this pregnancy might not be affected, but later on, she might have some effect on the next baby. So we should start now only to do that.
So the first exposure, the maternal antibodies are IgM, which do not cross over the placenta. So generally, the first pregnancy is not affected. And during and second exposure in the second pregnancy to the same antigen, the mother mounts an antibody response with IgG, which crosses over to the placenta and can cause hemolytic disease of the newborn. So we are talking about anti-D. Dr. Parna, how effective is anti-D in preventing this problem of RH aluminization?
So thank you, ma'am, and thank you, Dr. Shashilata, ma'am, and for having me here. So yes, anti-D is quite a good intervention to prevent RH isoimmunization. So if a lady who's RH negative and husband is RH positive, and we do not do anything, that the chances of RH overall isoimmunization would be around 14 to 16%. But if you give the antepartum, only the postpartum anti-D, the risk falls from 16% to 2%. And if you actually give antepartum also, then the combined risk actually falls to less than 1%. So it is a very, very effective intervention. And in fact, of course, we also know that ABO incompatibility is actually protective when you have anti-D, the D antigen incompatibility. So this is one intervention which has proven over time that it can really eradicate this disease completely. But of course, there are other factors to it. But if we do it very, very diligently and religiously, we can hope to have lesser incidences of alloimmunization.
So that is the message we would like to convey to all the obstetricians. So we know that most of the time there is transplacental hemorrhage going on, which is going on antepartum starts right from the first trimester. And as pregnancy advances, the chances of transplacental hemorrhage increases, and maximum is at the time of parturition. So 75 to 80% of cases of RH immunization are because of transplacental hemorrhage, which is spontaneous, and as little as 0.1 ml of fetal blood is enough to sensitize the mother. So Dr. Rima, what are the other events during pregnancy which can lead to sensitization? Dr. Rima, please unmute.
Thank you, Dr. Vatsala. Any invasive procedure which we perform, like a chorionic villus sampling, amniocentesis, or chordocentesis, increases the chances of fetal-maternal hemorrhage. Other modalities like external cephalic version, any suction evacuation that we do for an abortion, molar pregnancy, all of them can increase the chance of fetal-maternal hemorrhage and therefore increase the sensitization. Even a third trimester bleeding because of APH, abruptio, intrauterine fetal demise, and maternal blood transfusion, all of these are factors which are implicated in increasing the fetal-maternal hemorrhage. So these are the cases where we need to be careful.
Thank you, Dr. Rima. So we move forward. The patient has reached 28 weeks of pregnancy and the obstetrician has given her anti-D, but she asked for an Icd test at 32 weeks and it is positive in 1 and 2 dilution. And these are very common scenario. Patients are referred to us with Icd being positive in weak dilution, saying that the baby is going to get affected and the patients are very worried. So Dr. Kabra, how would you counsel such a woman?
In this case, this was not probably due to immunization. It was due to the vaccine. It is due to the anti-gamma globulin which was given, and the ICT is positive in 1:2 dilution because of this. So we can reassure the patient and we can counsel the patient, and there is no need to further do the ICT. And we should also tell the patient that this anti-D weak titer may persist for several weeks. And when we do DCT of the child of the newborn after delivery, then it may come positive also. So we should not worry about this.
Well, there's no need to repeat an ICD titer if you have given anti-D, unless you've given anti-D, mother has later, episodes of bleeding, whatever. But generally, there is no need to repeat ICD. Unnecessary will cause confusion. So, Dr. Nandita, the patient has done well and she has reached. Is there anything different in the management of labor and delivery from a woman who's not RH negative?
Who's not? Yes, definitely. Here we are talking about transplacental hemorrhage, which is maximum at parturition and in third trimester. So we will avoid all the maneuvers which might increase our transplacental hemorrhage. As you have rightly, as we say that, yes, no stripping of membranes or late ARMs in labor. There should be no fundal pushing, and there should be no manual removal of the placenta, early cord clamping. These are the methods which we use when we deliver an RH, deliver a RH negative mother.
And we usually don't want to go beyond term to minimize the risk of more fetal-maternal hemorrhage and sensitization. And
yes, not clamping the cord, no active, yes, this no MRP, but we have protect the vaginal and perineal wounds from laceration and fetal blood being spilled from the cord.
So similarly, at the time of cesarean also, we have to take these precautions because we're always in a hurry to deliver the placenta and we manually remove. So that should be avoided, and avoid spilling of blood into the abdominal cavity by using pads. So these are the precautions we can take to decrease the risk of sensitization. Cesarean section is also a condition which increases the risk of fetal-maternal hemorrhage and sensitization. So moving forward, Dr. Nandita, she's delivered. What investigations would you do for the newborn?
Yes, as soon as it is from the cord blood, we are going to take the hemoglobin to detect anemia, confirm the blood group of the baby. As we have already discussed, the direct Coombs test, yes, if she has been given anti-D, maybe weekly positive. Anti-D is given routinely within 72 hours after confirming the blood group. That means RH positive baby. When anti-D within 72 hours of the delivery is to be given.
Antepartum, it is like we give them, it's not like confirmatory, prophylactic, but after delivery, we only give it to
confirmation.
Yeah, after the positive babies. Right. Thank you. So prevention, we know that anti-T is effective, like Dr. Aparna said, and we know that 300 microgram of anti-T will neutralize 30 ml of fetal blood or 15 ml of fetal RBC. And in most of the pregnancies, the risk of 99% will have bleeding, which is very less than 4 ml. So this dose of anti-T is usually sufficient. But again, there are cases which may have large fetal maternal hemorrhage even after normal delivery and may go unrecognized. Another thing to remember is the half-life of anti-D is 24 days. And again, there's a debate about polyclonal or monoclonal, but polyclonal may have an advantage because it covers more epitopes, may be more effective. Monoclonal may have maybe a higher chance of not being effective to reduce sensitization. So Dr. Manisha, can you just summarize which are the women whom we should give anti-D, how much and when it should be given, just to wrap it up?
Yeah. So basically, we have to remember that we have to give anti-D only when the woman is ICT negative and not to give when she's positive. So that is also one of the problems like people advise. Right. So it has to be given only when it is negative. And if after delivery, we are getting the blood group done of the baby, and if it comes as positive, Rh positive, then we give anti-D, and it has to be given as soon as possible. So it's not that we have to wait till 72 hours. We have to give as soon as possible. And if 72 hours have elapsed, then also we can give, and it will be of some benefit at least. And we should try to give. So that's there. And in the antenatal period, if we are doing some procedures, as Dr. Rima has said, we give it before the procedure or just after the procedure. So as soon as possible, we give. So the procedures we have already discussed. And one more thing is we don't depend so much upon the DCT. If it's strongly positive, we don't give. So if the DCT is strongly positive, ICT is positive, then we don't give. Otherwise, we give if ICT is negative.
Thank you. So in common clinical practice, what are the other events or scenarios where you should give anti-D, which would like to convey the message to the practicing?
So basically, any abortion, ectopic pregnancy, we must give. H-hole, we must give. And apart from that, even in threatened abortions, and whenever you're doing some extra procedures, doing an external cephalic version, then also if she hasn't received, then you might offer and you might think of giving. So these would be the important conditions.
Right. We know the sensitizing events, so we have to cover them with anti-D. If it is in the first trimester, we can give a smaller dose, 50 to 100 micrograms. But that is not available, give 300 micrograms. It will not harm, but it is better to give to prevent sensitization. All abortions, whether medication abortions, surgical abortion, irrespective of POG, we should give. Even spontaneous abortions, we should give. And after invasive procedures, as Dr. Manisha has rightly told us, because the D antigen is expressed on the RBCs as early as 7 to 8 weeks, and a very small volume is required to cause sensitization. In the second and third trimester events, you would give 300 micrograms. So can aluminization occur even after anti-D? You have given anti-D, Dr. Kabra? What could be the
yes, aluminization can occur even after anti-D is given, because sometimes the antenatal dose is missed, though the dose at delivery has been given. So in that case, maybe the amount of anti-D given is not equivalent to counter the total effect of fetal-maternal hemorrhage. And sometimes the dose is less, like in early abortions or ectopic pregnancy. If the fetal-maternal hemorrhage was more and we have given less dose, like 50 microgram, 100 microgram, then aluminization can occur. Right. And sometimes multiple fetal-maternal, especially in case of placenta previa and massive bleeding, the dose may remain inadequate, because there is no, in India still it is not prevalent to do proper there is no practice of calculating the proper fetal-maternal hemorrhage in most of the hospitals. So that's the problem.
Other thing is anti-D you give is not going to cover for the other minor blood group antigen. So she may get sensitized to them. So there are certain events which we know cause large fetal-maternal hemorrhage, like abruption, cesarean deliveries, MRPs. after stillbirths, twin pregnancies. But again, then we don't have a routine method of determining fetal maternal hemorrhage like you have in other countries, although there are methods which we can use to determine the qualitatively or even quantify the amount of fetal maternal hemorrhage and give the anti-D accordingly.
Yeah, these tests we have been reading since our MBBS days, these Klehorbetke tests, flow cytometry and those, but still they are not so much used in Indian hospitals.
Yes, even for us to get it done in our hospital is not an easy task.
Yeah.
So
we are believing more on giving anti-D.
Yes. So moving forward, a few more tips about anti-D. No need to repeat at 40 weeks if the patient is not delivered. We can give it after delivery, after doing the baby's blood group. And weak titers may persist after anti-D injection, so that we should keep in mind and not panic. And if omitted, you can give within 14 days, even up to 28 days, it may be helpful. So there is still a window of opportunity beyond 72 hours. If delivery occurs less than 3 weeks from the dose of anti-D, so we don't need to repeat after birth because the half-life is around 24 days. And ideally, we should also give it to women undergoing postpartum sterilization. So it is a common scenario in which patients who are Rh negative, ICT negative, not IC-immunized, but have repeated episodes of bleeding late in the first trimester or the second trimester. So Dr. Aparna, how should we manage these patients?
Yeah, so thank you, ma'am, for the question. So this is a common situation in which a Rh negative mother, she has come to you with bleeding, so, and you have given anti-D once, and you are happy that you have covered her with anti-D. But it so happens that she starts bleeding again, maybe after 2 weeks, and a little bit of bleeding is happening. So how do we do is that, so we need to understand that once we have given anti-D, the ICT will remain positive for some time. So what we generally do is that we repeat ICT after 3 weeks. Now, if the ICT is negative, that means that the effect of your anti-D has gone. It is not there in the system already. It has been utilized to neutralize the fetal-maternal hemorrhage. And now, if the ICT is negative and the patient still had an episode of bleeding, then we will repeat the dose of anti-D. So that's how we do. Repeat ICT 3 weekly. If it is negative, that means you need to give. If it is positive, that means that it is still there in your system and you do not need to give. So it is generally 3 weekly ICT that we need to do and repeat anti-D as required.
So that is very correctly described. Or the RCOG guidelines even say that you may repeat at 6 weeks, after 6 weeks. So coming again to another case scenario. So here we have a patient who is Rh negative, but here we follow like in the first trimester, we do her ICT and we find that it is 1 in 2 because she received her postpartum dose of anti-D in the previous pregnancy, but antepartum dose was not given. So now the ICT titer is 1 in 2 in dilution. So how will you follow her, Dr. Kabra?
Dr. Vatsala, since this patient missed the antenatal dose, so probably she has developed sensitization. So in that case, I will follow her with ICT monthly. This dilution is very small, 1:2. So I will follow her with 4 weeks, every 4 weeks ICT. And once if it is going 1:2 or 1:4, then it is fine. But if it reaches the critical value 1:16, then we have to get her, we have to refer the patient to fetal medicine specialist, and we can ask for a middle cerebral artery PSV.
So very rightly said. So we should repeat, we can repeat it 4 weekly till 28 weeks, and then we can do it every 2 weeks. And once we reach the critical titer, there is no point of repeating ICT. Patient has to be monitored for fetal anemia by a middle cerebral artery, and she should be referred. So would you like to say, like, what is the critical titer?
1:16. At some places, it is taken as 1:32.
So right, so it is laboratory specific, and it is a titer below which no severe erythroblastosis or perinatal deaths have been observed. Yeah. So it varies from lab to lab. For us, it is 1 in 16.
Yeah, I would just like to add one more thing. The RCOG says something else. They usually express it in international units per ml, but that again, that is not 4 to 15 units. But that again is not practiced in our country. So we are more acquainted with this titer.
Right. So we don't quantify the amount of antibodies. We go by dilution. Right. So now coming back, so this is a case of first aluminized pregnancy. So as Dr. Kabra rightly said, we have to monitor them with ICT titers every 4 weeks to 28 weeks, and every 2 weeks, If she doesn't reach the critical titer, we are happy. We deliver her 37 to 38 weeks. We won't go beyond 37, 38 weeks because the risk of sensitization and fetal maternal hemorrhage keeps on increasing. If the titer reaches a critical titer, which for us is 1 in 16, we will monitor for fetal anemia. Again, here is a role of doing paternal zygosity and fetal blood group DNA if the father is heterozygous. Because if the father is homozygous, we know the fetus would be positive and this woman is at a risk of developing anemia. But if the father is heterozygous, we can do the fetal blood group in maternal, in free DNA in maternal circulation after she reaches critical titer in those cases also, because if the baby is negative, we don't have to subject her to frequent monitoring by ultrasound. And then we can reassure her that this baby fetus is not likely to be affected. So again, there is a role of doing the fetal blood group in cell-free DNA. And severe fetal anemia may not develop or develops late in pregnancy compared to subsequent affected pregnancy. So in a large series of 106 pregnancies, they found that 60% did not develop critical titer. And of the 40% who developed critical titer, only 26% had severe disease. Nonetheless, you cannot ignore, you need to monitor these patients carefully, the ones who have reached critical titer. So coming to patients who have had multiple immunized pregnancies. So what happens? These women would have some history, something like this, which we see very frequently. It's a multiparous woman, multiple losses. Either she had baby with neonatal jaundice or IUDs, hydrops. So this is what happens because as the patient, as like in every subsequent pregnancy, the disease affects the fetus more severely and at early gestation. And again, there is no point in doing Icd titers. We have to start with monitoring. So Dr. Reema, how would you monitor this case for fetal anemia now that she has has a critical titer?
Ma'am, so now detection of fetal anemia, we go by the middle cerebral artery peak systolic velocity, which is a very sensitive parameter with a sensitivity of almost 100% with a false positive of 12%. Because this is a very effective method, fetal anemia is depicted in the middle cerebral artery very effectively. And since it's non-invasive, there is no risk of fetal loss and there is no risk of exacerbating by invasive procedure. If we do chorecentesis to find out the hemoglobin, there's chance of exacerbation of the hemolysis. As you rightly depicted here, that invasive testing can also be done, amniocentesis to look at the bilirubin levels, which was done in the yesteryears, but no longer practiced in the current era, where we use Lely's chart to plot the bilirubin levels to give us the level where different zones were present and they depicted fetal anemia in the fetus. Currently, if MCA-PSV is more than 1.5 multiples of median moms, it's indicative of severe fetal anemia. And these are the babies where we subject them to chorecentesis, look at the anemia, and subject them to intrauterine transfusion.
So very rightly said, we are not doing amniocentesis for a long time because it is an invasive test. It is an indirect estimate of fetal anemia because you're measuring the bilirubin level. And there was very high chances of false positivity. So we're doing too many unnecessary invasive procedures because many of the babies would fall in Lily zone 3 as anemic were not actually anemic. Again, ultrasound had also been used and we have looked at many features, but none of the ultrasound parameter is sensitive enough to make a diagnosis of fetal anemia unless you find high drops, which is definitely suggestive, and that is not where we want to land up with. So ultrasound we use in also when we are doing ultrasound parameters, we also look at when we're doing MCA-PSV, but they are not very sensitive. So as Dr. Reema said, yes, middle cerebral artery peak systolic velocity is very accurate, but more important, also important is that we do the this thing in very accurately. So Dr. Reema, is it important, the technique? Yes, one has to be trained, yes, or anyone can just do it?
No, so yes, the technique is very important because there is high chance of false positive if the axial section that you take should include the thalamus, that's important, and the cavum septum pellucidum. So you have to be very sure in which plane you're going. The fetal should be at rest. The sample gate has to be at least 2 millimeters in size, and the sampling should be done at least 2 centimeters from the origin of the artery. And we need to be very sure of the angle of incination, which should be close to 0 degree. If we follow all these parameters, it's only then that will be very accurate in predicting the MCA accurately.
So yes, please carry on.
As a
Yeah,
marker
just
of fetal
I just
anemia.
wanted to add one line. This medial cerebral artery peak systolic velocity is a non-invasive method, and it has revolutionized the management of Rh negative pregnancy and completely replaced amniocentesis in many circumstances.
Definitely. So there's so many precautions that you have to take when you're doing the Doppler. So it has to be done by trained people. So if you find a critical titer, refer it to a maternal fetal medicine specialist who can monitor the patient and treat if required. So moving forward, why MCA PSV? Would you like to highlight, Dr. Rima?
Yes, so
Why this particular vessel is used, not other vessels?
So whenever there is fetal anemia, what happens is that there's increase in the blood viscosity, velocity, and this leads to increase in the cardiac output. The blood viscosity gets less, and this is very well depicted in the middle cerebral artery. Other vessels have been interrogated, like the umbilical, the descending aorta, common carotid. We have studies that they did try to find out anemia in these vessels, but the interrogation was not good enough, and the results were not very promising. Middle cerebral artery has stood the test of time. It's most reproducible, it's most promising, it's most accurate. The sensitivity is as close to 100% in predicting. If it's done well, all the parameters are performed, and it's the way forward. I mean, there's no other way of monitoring fetal anemia in today's era than the middle cerebral artery.
So you can avoid a whole lot of unnecessary invasive procedures by using MCPSP compared to amniocentesis. And again, the early study by Mari showed 100% sensitivity with only 12% false positivity. But a recent meta-analysis has shown a sensitivity is 86% and specificity is 71%. So that maybe in a research setting, it performed very well, but maybe in practice, it may not have that high sensitivity, but still this is the best method to go ahead for monitoring for fetal anemia. So how do we interpret it?
It's dependent on the weeks of gestation. So we have nomograms available where we plot it, and it's anything that falls between the range of more than 1.5 mom is indicative of fetal anemia. So it's different for different gestation. What at 18 weeks would be 34.8 centimeters would be the peak systolic velocity as 1.5 mom. It varies with the gestation, and therefore it has to be plotted on the graph, or we'll need to look at the nomograms to tell us whether this fetus is falling into the category of severe anemia.
So simple.
Can I ask a question, Dr. Vatsala?
Yes.
Do we have some Indian norms or anything, whatever we have done till now? Is that any different from some Western norms?
No, we are
for
using
MCA-PSV.
We are using the same cutoffs as published by Mari et al. And we also have a good sensitivity for first transfusion, almost 85-90%. It's not 100%. So we are using the same norms.
And some gestational age cutoff.
Since you mentioned, ma'am, the first transfusion, MCA-PSV performs very well, but with the second transfusion, the sensitivity is not as good. So they suggest that for a second transfusion, either we use the rate of fall, which is 1% per day, or it could be that we take it as, say, after 10 days, the first transfusion, 2 weeks, the second, or 3 weeks, the third transfusion. That's the gap that we give. Or it could be 0.4 gram per deciliter fall per day after the first transfusion, 0.3 after second, and 0.2 after the third transfusion. So we need to decide or take it as 1.7 mom as the need for transfusion after our first transfusion. So that also
or
changes.
any gestational age cutoff for reliability or any position of the head, which might
yeah. So like you have, like Dr. Rima said, you have to follow those criteria. Plus you should not be giving undue pressure, transducer pressure on the fetal head, and even sometimes maternal breathing movements can affect. So, and the planes have to be correct. So these have to be taken into account when you're doing, so that it is more accurate.
Yeah, can I come in, Dr. Vatsala?
Sure.
So as Dr. Nandita was asking, we did a thesis quite long back, and we also published it in International Journal of Gynae Ops, and in which we took 300 women, and we did like what we did was like those women who were going to deliver. So within 72 hours, we did the MCA, and we saw the cord blood also. So we found that the levels were slightly lower than that of Mary's. And because what Mary et al. Did was that they did the chordosynthesis in all like women. So they did it immediately. So we did it within 72 hours. So, but it was slightly lower, and we have made our own mammograms as such.
Dr. Manisha, any problems you had with term baby heads for the evaluation of MCA? Like
no,
the head
only thing
low
is
and-
if it is breached, then it is sometimes difficult. Otherwise, there wasn't much of a problem.
The other thing is it may not be very accurate after 35 weeks of gestation near term, but if you are following and the trend remains the same, you can continue using it for monitoring even beyond 35 weeks.
But it was quite good when we did the hemoglobin of the baby, cord blood hemoglobin. It was quite good even in those women who had like after 35 weeks also.
So as a rule of thumb, the 1.5 mom, which is moderate anemia, is twice the period of gestation. So at 20 weeks, it's like almost 38. At 26 weeks, it's 50 and 1.5 and 1. It's almost twice. So even if you don't, I mean, looking at the charts, if you just know like double the period of gestation, if the MCA-PSV is more than that, it will be most probably more than 1.5 or 1.55 moms. So once we reach a critical titer, we know that we have to go ahead and monitor with the MCA-PSV, and histories of previous affected pregnancies also we monitor. And since it is a non-invasive test, we start monitoring from 18 to 20 weeks, useful up to 35 weeks. And depending on the history, the previous history of loss, the severity of disease also we can know from the previous history. We may monitor them as frequently as 4 to 14 weeks, 4 to 14 days. And we can also see a trend for a patient. If you have done 2-3 values and the trend is the same, it is not rising, you can decrease the frequency. But for us, patients who have had many losses, previous high drops, previous history of intrauterine transfusions, we usually follow weekly for them, at least minimally weekly. So this is basically a flow chart which shows you that how you monitor with MCA-PSV once you reach the critical titer. If it is more than 1.5 moms and the POG is less than 35 weeks, you have to do chordosynthesis to confirm the diagnosis because it is not 100% sensitive. That is also a screening kind of a test. So you do chordosynthesis and decide for transfusion. If it is period of gestation is more than 35 weeks and MCA-PSV is more than 1.5, you may deliver after 35 weeks. If the trend is normal, you may induce labor at term. If MCA-PSV is less than 1.5, we keep monitoring sequentially. So now we know that we are going to monitor the patient. We do the first immunized pregnancy, we do the ICT. If it reaches a critical titer, we go for MCA-PSV for monitoring fetal anemia. With previously affected pregnancies, we also do fetal anemia. And then we find that MCA-PSV is more than 1.5, or there is ultrasound features of high drops. We suspect or we know that the baby is anemic. So we have to move forward to therapy, that is intrauterine transfusion. So we'll ask Dr. Aparna to tell us like what is fetal anemia, how do we diagnose fetal anemia, and how the procedure is done briefly.
So thank you, ma'am. So as we discussed here, so essentially the middle cerebral artery peak systolic velocity is indicating us towards the presence or absence of fetal anemia. For the threshold to decide transfusion, we need to have an anemia that is severe as we do in adults. So when we want to actually categorize severe anemia, we generally take a cutoff of something which is less than 7 grams per deciliter. So that is what we take. Now, when you take it as MOM, so Mari has also given charts where we see that, if the hemoglobin or multiple of median of hemoglobin at that particular gestation is less than 0.5, then again, it can be expressed as severe anemia, and that would decide our threshold for transfusion. So, and in terms of practice points, if we want to understand, and this is especially once we have transfused a baby, we will understand that we need to take a cutoff of hematocrit of 30% as a target where beyond which we will need to transfuse. So this is especially useful when we are using the rate of fall of hematocrit as a criteria for deciding the next transfusion. So once we know that the MCA-PSV is falling into the more than 1.5 MOM, we expect that this baby is going to have fetal anemia. And now we need to transfuse. So the process of transfusion would involve we should first have an idea of how much blood we want to transfuse, and that is a gestational age dependent or a fetoplacental volume dependent decision that we need to make. And that Mandelbrot formula is actually given by a deficit of the hematocrit that we are expecting. So we generally target a hematocrit of 45 to 50. And we expect a hematocrit of 21 because, if the patient is having a severe anemia. And that is multiplied by the fetoplacental volume, and that is divided by the hematocrit of the blood. So we generally have an idea of how much blood we want to arrange, because that's what we want to tell the blood bank. Now, the blood that is taken is centrifuged and irradiated, and so that it is leukodepleted. And once we have the volume of the blood which is ready and it is released from the blood bank, now a process of transfusion will start. So the first part of transfusion is the patient lies down on a table, on a OT table, on a transfusion table. You have a good ultrasound machine in place. The first part would be to localize the cord. Right. So, and if it's an anterior placenta, it's a happy thing and you can easily localize the cord. If it's a posterior placenta, it might be a little difficult. The best site is, of course, the cord insertion. So we need to know that if we are able to find the cord insertion, it's a fixed part of the cord and we are easily transfuse it. But there could be situations when it's a posterior placenta advanced gestation, you're not finding a cord insertion, then we go for a free loop of the cord. Of course, that's the next option. Another option now that we are also doing is the intrahepatic transfusion. It's been there for a while and it's also a fixed part of the cord. So hence it's a good place to transfuse. Now, fetal paralysis. Fetal paralysis is something which is very, very important, especially in the earlier gestations when the fetus is very active. So for that, we can give an intramuscular injection of what we are currently using is vecuronium. Earlier, we used to give pancuronium, that's no longer available. So we are giving vecuronium, which is given as an intramuscular injection in the fetal thigh or a fetal deltoid. Now, once that injection is given, and we know that the baby is now quiet, so we will target the cord. And once we identify under continuous ultrasound guidance, we will enter the cord with a sudden jab. Once we have entered the cord, we immediately withdraw around 1 ml of blood for hematocrit. And also if it's a first transfusion, we generally do the blood group of the baby as well. Once we have withdrawn that pre-transfusion hematocrit, we will transfuse the RBCs, which have already been prepared. And now this transfusion will take place. Now, when we are transfusing, we have, suppose we have transfused the requisite amount, then we will take the post-transfusion hematocrit after we have completed the transfusion. Now, we generally have hemocues with us, which give you the hemoglobin immediately. So we know that we have a certain amount of pre. As soon as we start the transfusion, we have taken the pre-transfusion, we do a hemocue, and we get the value of the hematocrit immediately. Based on that and a target that we decide, which could be 45 to 50 if the patient is non-hydropic, and it is lesser if it is hydropic. So even a 35 target could be good for hydropic. So that is what we take, and we transfuse the entire volume of blood. The post-transfusion, again, it is collected, and then we will do a post-transfusion hematocrit immediately after the procedure. And then we will, after the procedure is over, sometimes if it's a posterior placenta and the cord is, posterior, sometimes you might have a little bit of a backflow from the vein, and we should not really worry about it. So the umbilical vein, it will stop after some time. And yes, acute correction should be avoided, especially in hydropic babies whose, heart is already compromised. And once we finish the transfusion, we should confirm the fetal heart, especially after the period of viability. We generally put the patient on CTG for a while to see, any post-transfusion. Sometimes cord hematomas can happen. All of them can lead to fetal distress. So post-transfusion, we do keep the patients on CTG for a while. But pre-viability, we just look at the fetal heart, show it to the patient. And I think that is all we want to do about it.
So that is explained very well and elaborately, Dr. Parna. So I think I'll have another question for you. When do you start and when do you do the last transfusion?
I think we've been trying to push those limits on both sides. Yeah. So yes, we have performed our earliest transfusion even up to 18 weeks. And especially in those severe forms where, the hydrops is expected to happen very early and anemia develops. So we have done our transfusions around 17 to 18 weeks, that's possible. And now increasingly, we do our last transfusions at 34 weeks. 34, even 34 plus 4, 34 plus 5 weeks, because we do have an OT backup, and we have an immediate facility to do a cesarean section if we face any difficulty. But the deciding point whether we do a transfusion at 34 weeks plus 4 days or 5 days would definitely be the technical accessibility of the cord. Now, suppose if it's a posterior placenta and you're not able to see the cord, then definitely I'd not like to struggle. And because our nursery is so good, we'd like to deliver her maybe at 34, 35 weeks. But now increasingly we are trying to do the last transfusion between 34 to 35 weeks, so that we can take the pregnancies up to 37 weeks. So generally that is the plan now.
Yeah, and that's the standard of care everywhere. So besides monitoring for fetal well-being as such, how do we monitor for fetal anemia? So that I think Dr. Rima has already said that MCA-PSV is not so accurate after one transfusion. The sensitivity decreases if we use the same cutoff as 1.5. So what we do, we also do MCA-PSV, look at the other features of fetal anemia and ultrasound, but we also go by the rate of fall. So if we find the MCA-PSV is more than 1.5, we may go for transfusion. Otherwise, we also look at the rate of fall, because we have a post-transfusion hematocrit. So you rightly said, as you give subsequent transfusions, the rate of fall decreases because more and more fetal RBCs are replaced by adult RBCs. So we can make the transfusions less frequent. So the second can be after 10 days to 2 weeks, then 2 weeks, 3 weeks, like that. So yes, most of us would perform last transfusions up to 34, 35 weeks. So Dr. Manisha, it is an invasive procedure, so there are complications. So how should we counsel the patient? What are the outcomes like after intrauterine transfusions, and what are the complications that can occur with the procedure?
Yeah. So we have to really tell and counsel the patients properly, because it can be, it's an invasive procedure and very technically demanding one, we have to understand. So basically it can lead to some cord spasm or cord hematoma, especially when it is, given in a free loop. That's why Aparna was saying that we should try and see the cord insertion site more often. And it can lead to bradycardia more often. Like bradycardia is something like we look at the heart, and it can be, for some time, or it can be persistent, and we have to so that's why we have to keep the patient NPO and keep the OT ready, so that we have to take the patient anytime. So that is few of the complications. Apart from that, there can be hemorrhage, which can be a little bit severe also. They can be overload, like if it is a high drops and we are giving more, then it can lead to overload. So these are few of the fetal complications. About the maternal, it can lead to leaking from, it can lead to preterm labor, and maybe also choriomnitis, if like we have not seen, but it has been reported.
Yes.
So these are some of the complications.
So the success rate is very good, more than 90% for non-hydropic fetuses. And even for hydropic fetuses, we are reaching that figure recently because of better nursery care and better ultrasound machines. So procedure also becomes a little easier. And for all pregnancies which have reached viability, that is 26 to 28 weeks, give them steroid cover, because you never know which patient is going to have complication, and you may have to shift in for cesarean section. So the complications have been highlighted by Dr. Manisha, and the most scary one for us is a persistent bradycardia after the procedure, for which we have to rush in for a cesarean section. And of course, fetal deaths can also occur.
Yeah.
And so we also had a data published of 303 transfusions. So if for every procedure you do, the complication rate is almost 3%. And the risk of losing a baby for every procedure is 1.6%. And this is generally comparable to those reported from other centers in the world. So this is very peculiar to our situation, that we have patients like this. So this is a 7th gravida with only one living issue. So many losses because of RH isomerized pregnancy. And the previous pregnancy, the hydrops was at 22 weeks. So is there any way we can salvage these babies, or what can we do for these mothers? Dr. Nandita?
Expecting, if she has a risk, definitely it's a high risk RH isoimmunized pregnancy. 22 weeks, if she had a hydrops due to RH disease, we are expecting that the next pregnancy, it might be 10 weeks earlier. And so, yes, as you said, that we need some therapy till we start the definitive treatment. As we know that IUT earliest, 18, I'll say 22 weeks, if we can postpone it, So the methods which we are using is use of plasma exchange of plasmapheresis and use of intravenous immunoglobulin, which can reduce the severity. If the antibody load is high, it just reduces that IgG load, and the hemolytic process becomes delayed. So that helps in elevating the disease and just postponing the effect of, so that the hydrops does not occur. As you've already said, this is the mechanism. If we give, this is IVIG, plasma exchange also, I think we have covered.
So like you said, Doctor, that earlier, that it is in these cases also, it is important if we can look at the whether the zygosity for the husband.
Right, homozygous.
Yeah, because if the baby is Rh negative, we are happy. If the husband is homozygous, then we know that all the fetuses would be affected, and IVIG should be given, because again, it's a very costly drug, and you have to give it weekly in the dose of 1 gram per kg. So again, I mean, sure, in future, the role of doing paternal zygosity for Rh and for doing fetal D status in the maternal blood would be a very important test, actually. So this was following the Petit trial, which showed that if you give IVIG starting from 13 weeks onwards, before 13 weeks, you can delay anemia development by at least 3 weeks. So that is very important. If you can delay that, the later you do the transfusion, the chances of success, and technically it is easier. Any other option for these patients, Doctor?
Then the final answer is to change the genetic material. This is what we can have an IVF and check the zygosity, as you said. If the father is homozygous and repeatedly she is having antibodies against the this DD antigen, then the option remains in vitro fertilization.
We can go for PGT.
Yeah, so if the father is heterozygous, then you go for PGT. If the father is homozygous, we know all the fetuses will be affected. It's better to go for a donor sperm from a Rh negative father, or a gestational carrier who is not albuminized. Because we have had patients who are so fed up of repeated pregnancy losses that they don't want to conceive, even if we tell them that we can do IUTs and give you a healthy baby. So they may opt for, IUI with a donor sperm who is Rh negative. So thank you, everyone. We had a very, I think, productive and informative discussion. So it is important that all of us obstetricians should be aware of this condition and monitor carefully, beware when we have complications or we have a pregnancy who has having a critical titer, or we think the fetus is developing anemia, then refer to the fetal medicine centers right on time so they can be managed properly. Thank you. I thank all the panelists. I thank the organizers. Thank you, Ankita, for inviting me to moderate the panel.
Thank you so much.
Thank you, ma'am.
So are we taking any questions? Are there any questions in the chat box?
Can I ask?
Yeah, someone has asked about, yeah. Yes, please.
Yes, so I wanted to ask Aparna, if we are giving vecuronium to the baby, so can we do NST, the acceleration? So generally we wait for 2-3 hours and then we
Yes. So we wait. Yes, we definitely wait. I mean, of course we want to look at the deceleration. That's why we are doing the NFT. Okay. In fact, twice, once recently also it happened that we had to do a cesarean section following IUT and there were no breathing efforts. So then we always inform the pediatricians that, we have given vecuronium. So just electively give support. Otherwise, they'll think that why the baby is not breathing. So yes, it happens. But yes, of course, we are just looking to rule out a deceleration.
We usually put them in the labor room and put them on CTG till she starts perceiving movements. And in fact, there was one patient who was having persistent tachycardia. So finally, we took her up for section, and you wouldn't believe she had sort of bled from the puncture site so much that the baby was again anemic, and the LICA was all bloodstained, and that was causing fetal tachycardia. So it is really important to monitor them for the next few hours.
Okay. Yeah. We have, can I pitch in? Can I come in? We have switched on to IV fentanyl in these cases. instead of intramuscular vecuronium, just after
Function is
giving
different.
it in the cord.
The function is different, right? Fentanyl will be for pain
IV
relief.
fentanyl is also giving us that effect of slowing down the baby. IV fentanyl.
Maternal, transplacental therapy.
No.
Fetal.
Fetal.
Odd.
Yeah. So what
Fetal.
if it is an anterior placenta? It's easier. You can give it, and
In
till
the cord.
comes the chances of the needle getting dislodged is not there. But if it is a posterior placenta or something, then we prefer to give iron, because it takes some time for the baby to get paralyzed. And if the baby moves in between while your needle is in the cord, you may have cord accidents. Like you may traumatize the cord, you may have cord hematomas, and that can cause problems. So we also do, if it is anterior placenta, we give IV, pancuronium, we don't do 2 pricks, but if it is posterior or if you're planning to do intrahepatic, then we give IM and then proceed.
Dr. Vatsala, I must congratulate you for the wonderful panel. You know, the main topic of our webinar today was everything about Rh negative pregnancy. And you covered everything about Rh negative pregnancy in your panel. And
Thank
it was
you,
so
ma'am.
very kind.
Thank you, ma'am. I think the most important message is to prevent, which somehow doesn't seem to be happening. So I think there are 1 or 2 questions. So one is about what critical titer depend on the methodology, whether you do the tube method or the gel method. I think the gel method gives a higher titer, so we have to keep that in mind. We're usually using the tube method for looking at the titers. Cold chain will affect the efficacy of anti-D. Yes, that is very important in our country where we cannot really maintain cold chain even for vaccinations and all. So if you don't have cold chain, that could also be a reason for failure of after we have given anti-D. So that is also very important. And I think doing genotyping and NIPT has been covered many times. So I think most of the questions are also covered. So we can call it a day. Thank you very much.
Yeah,
thank you all the panelists for all the inputs. And I think we had some very good discussions in between also. Thank you so much.
So,
Thank
you, dear.
Thank you so much, Reese, for a thoroughly enriching and enlightening panel. All of us will be able to apply this knowledge to our practice and open a wider world to our patients. I request our chairperson, Dr. Shashilata Kabra ma'am, to say a few words.
Ankita, first of all, I will congratulate you. You are like my daughter. And you know, Dr. Mala Srivastava and myself are from same medical college in Calcutta. And at such young age, you know, you have done such a hard work. You have organized the whole program. You've invited all chairpersons, all speakers, everyone. And I really big applaud for you.
Thank you so much, ma'am.
And it was
all under your guidance. For every little thing I was asking ma'am and taking her guidance all along.
So you've done it very well, and you have organized it wonderfully.
Thank you so much.
The very purpose of giving a touch of multidisciplinary to the management of Rh negative pregnancy has been fulfilled.
Yes, ma'am.
So you can give vote of thanks.
Thank you, ma'am. On behalf of the organizing team of everything about Rh pregnancy, it is my privilege to propose the vote of thanks. First of all, I thank Dr. Achla Batra ma'am, President AOGD, and Dr. Joshna Suri ma'am, Vice President AOGD, to allow us to hold this webinar under the banner of AOGD. I thank Dr. Sheila Mane ma'am, our guest of honor and President ISAPA Bangalore chapter, who has spared her valuable time to grace this webinar. It's my privilege to thank Dr. Shashilata Kabra ma'am, Chairperson of AOGD Multidisciplinary Committee, who has guided me in organizing this program at every step. It's my privilege and pleasure to thank our esteemed chairpersons, Dr. Mandakini Pradhan and Dr. Seema Thakur, who are so experienced in their field and they have really contributed a lot in today's scientific deliberation. I take pleasure in thanking our star speakers of the evening, Dr. Veronica Roda and Dr. Manoj Modi, whose elaborate and exhaustive lectures have really benefited the delegates today. It's my privilege to thank Dr. Vatsala Dadwal, Professor, Fetal Medicine, AIMS, who has kindly agreed to moderate the panel discussion on management of Rh negative pregnancy. And really, it was an informative and a very exhaustive panel. I also thank the galaxy of star panelists, Dr. Shashilata Kabra, Dr. Reema Bhatt, Dr. Nandita Demri, Dr. Aparna Sharma, and Dr. Manisha for their immense contributions and their knowledge. I am sure all the delegates have highly benefited from today's e-learning, and I thank all the delegates who have logged in. I must thank Mr. Shivam and the Conference International and AOGD for providing the platform and the smooth running of the program. Thank you, everyone.
Thank you so much, Ankita. Thank you so much for all the work.
Thank you.
And good you finished on time.
Thank you so much, ma'am.
Thank you.